welcome to the deep dive. Now, if you're working the floor in a level 1 trauma center, controlled chaos, polytrauma, STEMIS, strokes, it's constant. But there's this one patient arrives, maybe looking okay, but can spiral into multi-organ failure, code even, faster than almost anyone else.
You're talking about the pregnant patient with severe preeclampsia.
Exactly. So today, we're diving deep into the sources, building a really precise, actionable protocol. How you stabilize this incredibly high-risk patient right there in the ED.
Yeah.
And there's this analogy from the source material. It's pretty blunt, but honestly, it feels accurate.
Which one?
That the patient isn't just having a problem.
Yeah.
She is the problem, like a grenade with the pin pulled.
Wow. Okay, yeah, that captures the time sensitivity perfectly, doesn't it?
It really does.
Because for you, the ER nurse, the mission is laser focused. You've got to spot the patient who's about to seize or stroke or abrupt and stop it cold. And your window before they ideally go up to L&D, we're talking 30 minutes, maybe less.
30 minutes. That's the hard target.
That's it.
Okay, let's make this real. Picture it. 2 a.m. triage buzzes you. 36-week pregnant female signing in. She looks pale. She's holding her head. Vision's blurry. Feels nauseous. Quick triage vitals flash up. BP 155 over 118. Heart rate 110. Sats 96 on room air.
Okay, stop right there. That is your immediate high alert situation. Full stop.
No waiting around.
Absolutely not. If you wait for OB to show up before you act, you've already potentially lost ground. This is an impending medical disaster. Stabilization has to start now in your ED room.
So that's critical practice for any level 1 center.
Essential.
All right, let's unpack that immediate action then. We always say time is tissue for stroke, for Stenage.
Yeah.
Time is literally seizure potential.
Precisely. Every minute counts.
So what criteria just bypasses everything else?
Yeah.
Gets this patient ESI level 1 straight to resus. You called triage a weapon here.
It really is, because that speed dictates everything that follows. So the non-negotiable criteria for ESI 1, any pregnant patient over 20 weeks gestation with a systolic blood pressure over 140 or a diastolic over 110.
Just one of those is enough.
One of those pressure numbers, yes, OR. And this is key. Any new acute neurological complaint, that severe headache she mentioned, the blurry vision, that counts.
So hit any one of those 3.
And they go straight back. No waiting room, no hallway stretcher, resus bay if needed, definitely into a room.
And the sources mention getting them into a quiet, dark room immediately.
Yeah.
Why that emphasis? Isn't the blood pressure the absolute first thing?
The pressure is critical, yes, but the environment is actually a non-pharmacological intervention. It's seizure prophylaxis.
How so?
Preeclampsia makes the central nervous system incredibly hypersensitive. Think of it like an exposed nerve.
Okay.
Every bright light, loud noise, sudden movement, it can act as a trigger. It lowers that seizure threshold. So quiet, dark room, minimizes stimuli while you get the meds going.
Oh, okay. That makes sense. You're calming the environment while you prep the internal fix.
Yeah.
Buying critical time.
Exactly. And during that time, it's all hands on deck. Monitors on, IV access, drawing labs, prepping meds, all happening simultaneously.
Because every minute fumbling for supplies
is another minute that brain is getting battered by that hypertension. You can't afford that delay.
Right. Okay, she's in the room. Monitors are on. Let's talk assessment. Confirming severe preeclampsia fast. You've got that NIBP machine reading 155, 118. Why can't we just run with that?
Because honestly, the stakes are just too high. Automated cuffs can be wrong. Wrong size, miscalibration. You need manual confirmation, always.
Get the manual cuff on.
Yep. And while you're doing that, you need to simultaneously dig for neurosymptoms.
Digging for neuro. Tell me more about that.
It means getting detailed. Don't just ask, do you have a headache? Ask where it is. How bad is it? Scale of 1 to 10. And crucially, what did you take for it? Did it help?
And the sources highlight something specific here.
Yeah.
The Tylenol failure.
Yes. This is a huge clinical clue. She says, yeah, I took my usual Tylenol, 2 tabs, and it didn't even touch this headache. That's significant.
Why does that specific failure matter so much?
Because this isn't usually your typical tension headache or migraine. A severe preeclamptic headache is driven by the hypertension, the vasoconstriction, Tylenol, so acetaminophen. It just doesn't work well on that underlying mechanism.
So if Tylenol fails, it points strongly towards the headache being directly from the preeclampsia.
It raises your suspicion way up. Yes, it's a really valuable piece of info right at the start.
Good practical tip.
Okay.
Moving to the physical exam, we're hunting for what the sources called the unholy trinity.
That's right. We've got the hypertension confirmed manually. We've dug into the headache details. Now we need to check for hyperreflexia. You have to put your hands on the patient, check those deep tendon reflexes.
Looking for briskness, like +3, +4.
Exactly. Are they super brisk? +4 is obviously hyperreactive. But the most profound sign, the one that really screams CNS irritability without the patient saying a word, is clonus.
Clonus. Okay, walk us through checking that properly. For nurses maybe not doing OB checks every day, this might be rusty.
Sure, it's straightforward. Have the patient lying down, leg relaxed, maybe slightly bent at the knee. You support their lower leg or ankle.
Got it.
Then, with your other hand, you take their foot and give it one quick, sharp dorsiflexion. Pull the toes up towards the shin, fast, and then hold that pressure.
And what are you looking for?
You're looking and feeling for the foot to chatter or beat rhythmically back against your hand, like tapping. That's clonus.
How many beats? Does it matter?
Even a few sustained beats, like 3 to 5 or more, that's significant clonus.
Whoop.
It's a huge red flag. It tells you the brain is highly irritable, basically on fire, like we said. A seizure could be imminent.
Wow. Okay, so brain status checked. Hypertension, headache, hyperreflexia, possibly clonus. What other organs are getting hit? Where else do we look?
Remember, this thing goes for the KO, brain, liver, lungs, so you assess those. Palpate the right upper quadrant. Tenderness there, that suggests the liver is involved. Could be swelling, inflammation, maybe even heading toward HEL-LP syndrome or worst case rupture.
In the lungs.
Auscultate. Listen carefully at the bases. Are you hearing fine crackles? That could be pulmonary edema starting fast. The heart's struggling against all that pressure, that afterload, fluids backing up.
So you're systematically checking for that multi-system failure starting.
Exactly. Brain, liver, lungs. Hit those key assessments.
Okay, assessment's painting a clear picture. Severe BP, neurosymptoms, maybe clonus, maybe RUQ pain. We need help fast. What's the activation?
You hit the code OB button, or whatever your hospital's equivalent is, and we need to be really clear. This is not just a consult call.
Right. It's not a casual page.
No, it's an activation. Just like code trauma, code STEMI, code stroke, it means all hands on deck now. It summons the cavalry, OB team, L&D nurses, anesthesia, NICU. They all need to mobilize to your ED room immediately.
And importantly, until they physically arrive and take over aspects of care, the ED nurse is still running the show.
You are the quarterback, absolutely. We know the only definitive cure is delivery.
Right. Get the baby out, get the placenta out.
But our job, the ED's job, is critical stabilization first. Make her safe for that transfer, or whatever comes next.
Okay, let's talk tactical stabilization protocol, the actual sequence. We have two huge immediate threats, seizure and stroke from that BP. Which medication goes first?
Seizure prevention first. Always run the magnesium shield immediately.
Magnesium first. Explain the thinking there. Why not hammer the blood pressure down right away to prevent the stroke?
It's a tactical decision based on immediate risk. While the hypertension is driving a lot of this, an eclamptic seizure itself can cause immediate catastrophic harm to both mother and baby. Irreversible brain injury, fetal distress.
Okay.
Magnesium sulfate acts directly on the CNS as a depressant, an anticonvulsant. It needs to get loaded quickly, that's the bolus, to raise the seizure threshold and stabilize the brain right now.
So you shield the brain first.
Shield the brain, then diffuse the hypertensive bomb. That's the sequence. Get that mag bolus running 2 grams, 4 grams, maybe even 6, depending on your protocol.
Check your local protocol.
Definitely check your protocol, get it infusing, then start the maintenance drip, usually around 2 grams per hour.
Yeah.
And of course, you're watching closely for signs of mag toxicity while you manage everything else.
Okay, mag is running, brain is shielded. Now we tackle the pressure. Diffuse the hypertensive bomb. First line agent.
Labetalol 4V push. And this requires real discipline. Stick to the sequence.
Let's hear it step by step.
Okay, start. Labetalol 20 milligrams IV push. Give it slowly over about 2 minutes.
2 minutes, got it.
Then you wait 10 full minutes. Reassess the blood pressure. No sooner. Let it work. If, after 10 minutes, the systolic is still over a 140 OR, the diastolic is still over 110,
Okay.
you escalate.
Oh.
Dose 2. Labetalol 40 milligrams IV push, again over 2 minutes.
Wait another 10 minutes.
Wait another 10. Reassess again. Still refractory, still above those thresholds.
Yeah.
Final escalation dose. Labetalol 80 milligrams IV push.
20, then 40, then 80. 10 minutes between each.
That's the rhythm. That systematic, timed approach prevents you from accidentally bottoming out the pressure, which could compromise placental perfusion. You need controlled descent.
Makes sense. What if we've given the full 80 milligram dose and she's still severely hypertensive?
Hmm.
Or what if she can't get labetalol? Say she has bad asthma.
Then you pivot quickly to your second-line agent, which is typically hydralazine,
Yeah.
usually 5 to 10 milligrams IV push. But here's the warning. Hydralazine can sometimes cause a really rapid, significant drop in pressure.
Precipitous drop.
Yeah, and it often triggers a reflex tachycardia. The heart rate can shoot up, which might not be well tolerated either. So if you give hydralazine, you need to monitor that heart rate even more closely, along with the BP.
Good heads up. Okay, meds are going in. What about access and labs? Need lines, need data.
Absolutely. 2 large bore IVs, minimum 18 gauge, bigger if possible. You need reliable access. And labs. Here's a pro tip. Something seasoned trauma nurses do. Draw 2 complete sets of all your labs right at the beginning. Full preeclampsia panel, CBC, comprehensive metabolic panel for LFTs and renal function, coags, lactate maybe, everything.
2 full sets. Why the duplication?
It's pure risk mitigation. Think about it. What if that first set of tubes gets lost on the way to the lab? Or it clots? Or the draw was difficult and the sample hemolyzes?
Ugh, yeah, that happens.
And then you're stuck. You've lost maybe 30, 45, 60 minutes waiting for a redraw, waiting for results. Critical time when you need to know if she's developing HEL-LP syndrome, for example.
Right, that changes management drastically.
Completely. But if you drew that second set right at the start and you have it sitting right there in the room.
You just send the backup set immediately.
Exactly. You lose maybe 5 minutes instead of an hour. You save the patient another stick. You keep the momentum going. It's a simple thing, but it can be incredibly valuable.
That is a fantastic practical tip. Keep a set on standby.
Oh.
Okay, so let's fast forward. We got the mag running. The lab all worked. Maybe we needed the 40 milligram dose pressures down to 122/78. Clonus seems resolved. The cavalry, the OB team, anesthesia, they're here. Our job in the ED is wrapping up when?
Your primary mission is complete when you can hand off a non-seizing, hemodynamically controlled patient. That's the goal state.
And that handoff needs to be tight.
Absolutely. Structured, formal SBR. No ambiguity. You need to clearly communicate her status now and every single intervention you did to get her there.
Okay, let's practice that SBIR using our example patient, Jane Doe. You're calling the L&D nurse.
Okay. Ring, ring. Hi, this is nurse's name from the ED. I'm calling report on our code OB patient, Jane Doe. We're sending her up to you now. That's S situation.
Got it. B background.
She's a 36-weeker, came in with a severe hypertensive headache and visual changes. Initial BP was 155/118. On exam, she had obvious clonus.
Clear picture. A. Assessment. Where is she now?
Assessment is, she received the full 4-gram magnesium bolus, now infusing at 2 grams per hour. She got 20 milligrams and then 40 milligrams of labetalol 5E push. Her last BP was stable at 122/78. Clonus resolved. We have 2 good large bore IVs running saline lock, basically. And her labs, the double set we drew, are cooking now. No urine output measured yet in the ED.
Perfect. And R. Recommendation request.
Recommendation is transfer to L&D now, just confirming if you want her in a specific L&D room for likely delivery prep or an observation spot first. And any immediate orders you have, like stat magnesium levels on arrival?
That's crystal clear. You've taken that grenade, followed a precise protocol, and handed off a stabilized patient safely. That's excellent level 1 nursing.
It really is. And the key takeaways, the things to burn into your practice. Know those ESI level 1 criteria cold. Pregnant, 20 weeks, BP 140 systolic or 110 diastolic, or any new neuro symptom. Straight back.
Straight back.
Discipline and assessment, manual BP confirmation, hunt for that clonus, and therapeutic discipline. Magnesium shield first to prevent the seizure, then the strict labetalol sequence for the BP. Manage the immediate threats in order.
Mag first, then BP.
Got it.
And draw those double labs.
Definitely remembering that one. Okay, here's a final thought then, something for you to take back and maybe discuss with your team. We know the goal is stabilization for delivery. That's the ultimate treatment.
Right.
So what if your ED interventions don't fully work? You've given the mag bolus, you've run through the entire labetalol protocol, maybe even given hydralazine, and she's still severely hypertensive, still symptomatic, maybe still has clonus.
Yeah, that's a scary scenario.
How does that failure to stabilize shift the mental timeline for you as the ED quarterback? Especially if OB or anesthesia hasn't physically arrived yet, or transfer is delayed for some reason. Does that reality maybe force a mental shift from stabilizing her towards actively preparing for an emergency in ED delivery if things go south fast? Oof. That's a heavy question. What are our capabilities and triggers for that?
Something to definitely think about and maybe even drill before the next code OB hits. Thanks for diving deep with us today.
Always a pleasure. Stay safe out there.